Today we're going to discuss the vascular system. First of all, you must understand there is a clear differentiation between the arterial and the venous system. The arterial system is pulses, whereas the venous system is varicose veins and chronic venous insufficiency. Today's talk will be focusing only on the arterial system and limb ischemia. Before you approach any arterial examination, one must clearly understand the anatomy involved and understand all pulses and where they are to be found in the patients. At the end of your history and clinical examination, you should be able to answer 6 questions. These are fundamental in both the management, treatment, and intervention in these patients. One must understand that history is an active process, and one must clearly listen to the patient for subtle hints as to their disease, the severity, and the progression of their sickness. If we look at this slide on history, you can see that a large proportion, all that is marked in green, clearly indicates what one can achieve by just listening to the patients. And the small part is examination, marked in orange. On history, the first thing one wants to do is to clearly determine whether this is chronic or acute. Chronic limb ischemia is determined by a gradual onset and is mainly determined due to atherosclerosis, whereas acute limb ischemia is more a sudden onset and usually embolus or thrombosis. We usually define chronic limb ischemia as occurring over greater than 14 days, whereas acute limb ischemia will occur in less than 14 days. The next question we need to determine is what risk factors this patient has. We divide our risk factors into those that are modifiable and those that are non-modifiable. Non-modifiable in atherosclerotic disease is age, race, and gender. We can do very little about that. One is always going to be born male or female, you will get older, and your race is predetermined. So we cannot intervene there as medical professionals. Whereas we can intervene in the modifiable risk factors. The main modifiable risk factors are smoking, diabetes, hypertension, and hyperlipidemia. In terms of history of the smoking, we need to know for how long has the patient been smoking, what have they been smoking, and for how much have they been smoking. Diabetes. We need to know, is the patient insulin-dependent diabetic or non-insulin dependent diabetic? For how many years have they been under treatment and what treatment they are on? Hypertension. We need to know how long the patient has had hypertension, what treatment they are on, and whether their hypertension is controlled or uncontrolled. Hyperlipidemia. We want to know whether there's a family history of it. We want to know whether the patient is on medication for it, dietary modifications the patient may be doing. In acute limb ischemia, we're looking at 2 main etiological causes, embolus and thrombosis. If we look at embolic disease, we mainly have 2 types, cardiogenic, which is cardiac arterial emboli, or non-cardiogenic, which is arterial, and then we have the other, or the idiopathic, which we are not going to focus on during this discussion. Cardiogenic examples of things that could be determined on history would be, for example, atrial fibrillation, which may form a clot and embolize to a limb. Non-cardiogenic emboli might be a plaque that breaks off in the aorta and goes to the foot. That would be an example of an arterial or non-cardiac embolus. Thrombosis is usually due to plaque rupture and underlying atherosclerotic disease, which may cause an acute occlusion of that limb, and it is important to determine whether the patient has got atherosclerotic risk factors in that case. Hypocoagulable states are important to determine, and this could be determined on a family history. Has the patient previously had clots form or occlusions form? Is the patient on any anticoagulations for this? Have they had histories of miscarriages, as this can give us clear indications of the likely hypercoagulable state? And has the patient had a previous bypass graft, because these can acutely occlude and can lead to severe ischemia in a short time. The next important thing to determine is whether the patient has any systemic manifestations of the disease. If we look at chronic limb ischemia, we basically divide the systemic manifestations into 3 groups: cerebral, coronary, and mesenterial. For example, cerebral disease could present with a stroke, TIA, RIND, or Amarugos fuga. Coronary examples would be a patient who's had a previous myocardial infarction, angina, whether the angina is stable or unstable, and mesenterial disease. Examples would be mesenterial ischemia or fear of food. Has the patient got postprandial pain that is stopping him eating, and is he losing weight? The reason why these are important is they impact in our overall treatment of the patient and on the risk of surgery or intervention. If we look at acute limb ischemia, as earlier stated, it's either due to embolic disease or thrombotic disease. One must understand that if an emboli comes out of, for example, the heart, this emboli can potentially go to any site in the body, not just the limb. So it could go up a carotid artery, for example, and cause a stroke. It could go to the intestines and cause acute dead intestines. Or it could go to the kidneys and cause hematuria. It is important to be aware of this so one can go and look for it and treat these conditions and help the patient. One must also understand that the quicker one is reacting to these in acute limb ischemia, the quicker and the better the patient's prognosis is. The next question we have to answer is the severity of the ischemia. We basically divide chronic limb ischemia into three groups: whether the patient is asymptomatic, whether the patient has claudication, or whether the patient has critical limb ischemia. If we look at the first group, or the asymptomatic group, this is defined as patients with no symptoms, but an ABPI, or an ankle brachial pressure index of less than 0.9. One may ask, why is this important to determine if the patient is asymptomatic? This is important to determine for the reason that this patient is at an increased risk of other systemic manifestations of their disease, such as cerebral, coronary, and mesenterial diseases. And we can, by intervening in their risk factors, impact this patient's life expectancy as well as their future. Claudication. Claudication is classically described as a patient that walks, experiences pain, has to rest for approximately 10 minutes, and then the pain will subside and the patient is able to continue walking. This is more severe than asymptomatic, but less severe than critical limb ischemia. These patients need both advice, risk factor modification, and medication intervention, and is important to determine for these reasons. Critical limb ischemia is the most severe. These patients have rest pain and or tissue loss and or gangrene with an ankle pressure of less than 50 millimeters mercury, or in the toe less than 30 millimeters of mercury. We need to intervene on them in a multitude of ways. The first way is with education, second way is with medication, and then the third way, we need to do some sort of surgery on these patients. If we look at acute limb ischemia and the severity of the ischemia in this group, we divide them into four groups: the viable, the marginally threatened, the immediately threatened, and the irreversible. We assess four things in these patients. We look at both the motor function of the foot, the sensory function of that foot, whether the patient has arterial Doppler flow, and whether the patient has venous Doppler flow. We are then able to classify them into these four groups. To make it simple for you, a viable foot is when all four of those above, motor, sensory, Doppler arterial, and Doppler venous flow, is present. And an irreversible limb, or a dead limb, is when none of them are present. The 2A and the 2B, therefore, are in between those two groups and indicate urgent intervention is needed. Comorbidities in both chronic and acute limb ischemia can be in two distinct groups, and we need to understand that. Chronic limb ischemia can be any diseases that would affect outcome. This includes anesthetics, surgery, or the patient's overall function. So it is important to determine whether the patient has renal impairment, for example, as this would impact on our imaging modalities that we would be allowed to use. So for example, a patient with renal impairment, we would not want to use a CT scan with contrast. Respiratory disease is very common in the chronic limb ischemic group, as the patients are smokers and have a high incidence of COPD. So a general anesthetic, for example, might want to be avoided. Mobility is important. So for example, a patient that has not walked in the last 10 years, you might decide to do a primary amputation for a patient as they're not going to use their limb anyway. In acute limb ischemia, we must understand that therefore the etiology of the disease is different. Therefore the conditions or the comorbidities that these patients might suffer might be different. So for example, respiratory disease is much less common in the acute limb ischemia group, but renal impairment could occur secondary to an embolus to the renal arteries. Also, we must understand that comorbidities in acute limb ischemia can be related to the embolus, as described earlier, that goes to different organ systems. So a patient that has an embolic event to the kidneys or to the intestines might take precedence over the limb in order to be life rather than limb saving. Now we come to the exciting part, on examination. But please remember that the examination is still only a small part in the 6 questions that we are going to come to. If we look at this table, we see that the small percentage that they play in the role of determining acute or chronic limb ischemia and the 6 questions. Now with any examination, we have examination tools that are available to us. These are inspection, palpation, auscultation, and percussion. During this talk, we will only be covering those that are relevant to the vascular examination. But one must remember that one must examine all organ systems in all patients, and a head-to-toe approach is still the best. On inspection, we want to know the color of the limbs.
We look at muscle wasting, previous surgery. There's a scar on this side, and then there's an even clearer scar on that side. We look for hair loss, which is very difficult in this patient to tell. Toes. We look in between each toe. He's got a clear wound in between these 2 toes. I'm just looking at each one. That looks fine. You can also see the color difference between the
2. The vascular angle, i.e. whether the foot gets pale on elevation.
You can see how nice and white it's going. And if we keep that whiteness and keep that in mind, and we'll see what will happen now as the foot goes red.
The capillary filling time. Does the one foot take longer to revert back to its normal color than the other one? And the venous filling time. Palpation. We examine the temperature, comparing the one limb to the other limb. Is one limb warmer than the other? Is one limb, for example, in infection? Is one limb colder than the other, for example, in acute occlusion? Or are both limbs more or less the same temperature? Capillary refilling. How long does it take the vessels to refill? Is one side delayed as compared to the other? And we will look at the pulses. The one thing one must remember with palpation is that you have 2 limbs. Therefore, always compare one side to the other side, because each of us is different. If we look at which pulses we must examine the radial pulse, we must examine the brachial pulse, one must examine the carotid pulse on the right side, and the carotid pulse on the left side. The reason why I highlight the carotid pulse is that the carotid pulses must never be felt left and right at the same time. The femoral pulse we will feel for. The popliteal pulse we will feel for.
Buig die been van my asseblief mevrou. So rustig. About 45 degrees. Relax the muscles. Moving your fingers medial and lateral. And the heads of gastrocnemius out of the way. Feel for the pulse. This lady has a pulse on this side. And we check the opposite side in a similar manner. Bend your leg to about 45 degrees. We're feeling for the popliteal pulse here. She does not have a popliteal pulse on this side.
And the dorsal pedis pulse. The posterior tibial pulse we'll feel for. All of these must be done in all limbs. If we look at auscultation, we listen over two areas. We listen for a bruit over the carotid area and over the femoral area. And we listen for the Doppler signal in acute arterial occlusion. Here are examples of a bruit, and here is an example of Doppler. We have covered the severity of the ischemia already, and so I will not cover it again here, but it is partly examination and partly history that needs to be therefore determined. If we look at the segment involved for chronic and acute limb ischemia, we can notice that both in a chronic and acute limb ischemia, the segments are the same. We must also notice that this is only lower limb. So if we look at the first one, aorta-iliac segment. Aorta-iliac segment means that a femoral pulse is not present in either the left or the right groin. Unilateral iliac disease is a bit more complicated. This can mean one of three options. Option 1, a femoral pulse is palpable on one side and not on the other. The side that the pulse is not palpable is your diseased side, so it could be a left or right unilateral iliac disease. Option 2 is that both pulses are palpable, but one is weaker than the other, and this would indicate disease on the weaker side. The third option is that a pulse is present, they are equal, but there is a bruit. If there is a bruit, this indicates to us that there is turbulent flow and hence disease in that iliac segment. The next segment to discuss is the femoropopliteal. The femoropopliteal segment would indicate to one that the femoral pulse is present, but the popliteal pulse is not present. Tibial artery segment would indicate to us that the popliteal pulse is present, but the tibial posterior and the dorsal pedis pulse is absent in this particular limb. Microvascular disease would be indicated where both the dorsal pedis pulse and the tibial posterior pulse are present, but the patient still has severe ischemia in that limb. If we look at in conclusion, we can first of all see that a large proportion of these questions can be answered on a history, with some being helped with a bit of history and a bit of an examination, and a small amount is answered on just the examination. Severity is important to determine, as this indicates to us the urgency of the intervention. How quickly must this patient get to theatre? How much time do we have for investigations? How much time do we have to optimize the patients? Can we treat them for their pneumonia, for their COPD prior to taking them to theatre, or will that be detrimental to the limb? This is a very advantages versus disadvantages and is often very difficult to determine. We also need to know the type of intervention. So for example, a patient that has got a severely threatened limb will need urgent revascularization, whereas a patient who has only a marginally threatened limb, we might have time to give thrombolytic therapy, which takes a bit of time to work, but we have got the time. It is also important to understand that this patient might need further management. So for example, a patient that has had a plaque rupture has got atherosclerotic disease and will need further management in the future to mitigate that risk factor. Comorbidities. Chronic limb ischemia and acute limb ischemia have different comorbidities. These must be elicited on history, and it's anything or something that will affect the surgery. We divide these into basically three groups: the preoperative comorbidities, and the questions here to be asked are, can we improve on them? Can we get the patient in a better condition? Or do we not have any time? We can't improve the patient. Anything that might impact intraoperatively. So for example, a patient in renal failure, we may not want to give intraoperative contrast agents to avoid the nephrotoxic effects of those drugs. Or in the postoperative period, a patient with COPD rarely has problems in the preoperative or intraoperative period, but for example in the postoperative period may have severe lung compromise and may be needed to be treated in an ICU. This helps us predict likely complications, likely problems, and this therefore helps us to better manage the patient and ensure a better outcome for the patient